Morning, sirs. I'm here to present a case series of syphilitic uveitis in a tertiary care institute of Northeast India. So uveitis represents the most common ocular manifestation of acquired syphilis in the eye. There has been a resurgence in cases of syphilis globally over the past decade, and in 2015, the CDC reported a 7.5% prevalence of primary and secondary syphilis. Ocular manifestations occur in about 0.6 to 2% patients with syphilis at any stage of the disease. So in case 1, a 23-year-old male with diminution of vision of the left eye presented with BCVA 6/18 with AC cells +2, vitritis +2, and multifocal peripheral active vasculitis and chorioretinitis as seen in this picture. He had a history of exposure with a male partner and tested positive for RPR with a 1:32 titer, TPHA, and HIV. CSF analysis and MRI brain showed no signs of neurosyphilis, and he was started on the neurosyphilitic regimen of benzathine penicillin 2.4 million international units IM weekly for 3 weeks, and ceftriaxone 2 gram once daily for 14 days. He was also started with ART with cotrimoxazole prophylaxis and topical prednisolone and homatropin. And 1 month follow-up, his BCVA had improved to 6.6. Uveitis had resolved. Multifocal chorioretinitis lesions became pigmented and quiet, giving the salt and pepper appearance as seen in this picture. And repeat RPR titer was 1:8. In the second case, a 50-year-old female with painful diminution of vision of the right eye had BCVA of 6.9 with AC cells +3, posterior synecdoche. She had vitritis +2, mid-peripheral active retinal vasculitis with retinal hemorrhages, as we can see in this picture. And she had a past history of polymorphous skin lesions in forearms. She tested positive for RPR with 1:128 titer and TPHA, and she was treated similar to the first case. And her partner also tested positive and received treatment. And at 1 month follow-up, her RPR titer had reduced to 1:32. However, she had AC cells and some fresh retinal lesions, and she was restarted on oral doxycycline 100 mg BD for 14 days. At 2 months follow-up, her BCVA had improved to 6.6, and AC reaction, vitritis, and vasculitis had resolved. A case 3, 46-year-old hypertensive female with diminution of vision had BCVA of 6.12 with vitritis +2, peripheral retinal vasculitis with exudates and hemorrhages, who tested for RPR 1:2 titer and TPHA. She received benzathine penicillin and oral doxycycline as she was allergic to ceftriaxone. Her partner also tested positive and received treatment. And at 2 weeks follow-up, her BCVA had improved to 6.6 with vitritis resolved and no new lesions seen. A case 4, a 28-year-old HIV positive male with acute onset diminution of vision had floaters for 1 week with BCVA 636, AC cells +2, vitreous cells +2, vitreous haze +2 with early established disc edema. And he was treated similar to the first case. And at 1 month follow-up, his BCVA had improved with no AC reaction and vitritis and reduced RPR titer. Syphilis was diagnosed based on ophthalmic manifestations of uveitis in all 4 patients, aided by treponemal and non-treponemal serological tests, TPHA and RPR respectively. Dermatological manifestations were seen in 2 patients. HIV co-infection was seen in 2 patients. In 2 of them, the sexual partners had tested positive. All patients received the neurosyphilitic regimen with dramatic clinical improvement in signs and symptoms, and BCVA improved in all 4. At 4 weeks, RPR titer reduced 4-fold in 3 patients. This is a summary of the 4 cases. In conclusion, syphilitic uveitis is considered a great masquerader, posing a diagnostic challenge to all clinicians. Re-emergence of syphilis and its numerous ocular signs and symptoms make it necessary to keep it as a differential diagnosis for all uveitis. Due to the high incidence of HIV co-infection, all patients with ocular syphilis must be tested for HIV as it changes the natural course of the disease. Ocular syphilis requires neurosyphilitic therapy regardless of when it develops after primary infection. These are my references. Thank you very much.
Can you please show your summary slide?
Yes, sir.
So I think that in your 2 patients, that RPR titer was very low. And I think that was not significant.
So 1:2 we had gotten, and we consulted with, so we took a medicine.
I think 1:2 is not significant.
But then we were, because her partner also tested positive, it was, we went ahead with treatment.
So the partner was positive doesn't mean now that
Yes.
the other person was having that syphilis.
Yes, sir, but
But that,
because
because
she
that
had
RPR,
ocular
that RPR,
manifestation.
that RPR was not
1:2.
significant.
Yes, sir.
Yeah.
That so
And
that was
again,
a.
that EPHA can be positive in so many conditions.
So we had
Was
a.
positive.
Yes, sir. We had a. In the department, we had discussed this issue, but because for ocular manifestations as well as by then we had also tested her partner, so it
And
had
have
been.
you followed up those patients who were RPR positive later on?
Yes, sir. So we had repeated the titer and.
So when you stopped the treatment, when
So-
you decided that the patient is now cured for
So,
syphilis,
so in literature, they mention a fourfold reduction in the titer as a significant reduction that is there. So these patients are still on follow-up. The last patient is lost to follow-up, sir. They are so doing well. There's no active, no fresh lesions, no recurrence, and the titer at last visit had reduced quite significantly. It is so we did RPR only for those patients.
okay, thank you.
Thank you, sir.
You have a very nice collection of syphilitic cases, Dr. Pritisha, I must say.